Thank you, Matthew. And on behalf of myself and the Public Health Institute, our sponsors, our supporters, and everyone else in this room, I want to say good morning and welcome to our first ever National Opioid Summit put on by the Public Health Institute. As Matthew said, we have been thinking and working on this for quite a while, and we actually scheduled it to be able to have the U.S. Surgeon General here, and I think when he speaks, you'll understand why it was important for us to schedule to his availability. And then what we realized was we have a whole room full of experts, so I'm very excited about the day. Let me tell you just a little bit about the Public Health Institute for those of you who might not be familiar with us. PHI has been serving the public health community for here in California, across the country, and actually across the globe for 55 years. We work in virtually every area that's public health, and you know that's broad, from helping end child marriage in Malawi to creating health food policy right here in California. And we are privileged with support from the state of California and the federal government to now lead the biggest opioid coalition right here in California, the largest one in the country. I won't go into details because Dr. Carmen Navarez will be talking more about that later. But before we begin, I want to thank our sponsors who have made today possible through their generous support. First, I'm going to start with the California Healthcare Foundation because Kelly Pfeiffer was the person who really believed in this. Followed quickly by the California Department of Healthcare Services, the California Endowment, Patient-Centered Outcomes Research Institute, and Kaiser Permanente. I also want to thank our supporters. These are the people who shared information, time, expertise, and helped us get the word out about this meeting to all of their colleagues who were working every day in the field on the opioid epidemic. The American Public Health Association, Trust for America's Health, the Latino Coalition for a Healthy California, Society for Public Health Education, and the U.S. Department of Health and Human Services Region 9. I also want to thank all of our speakers and their staff who gave us good ideas as we were planning this meeting. We didn't have all the answers, we didn't even have all the questions, but as we had conversations with the people who you will be meeting with today, they helped shape and form the way this meeting will be going. And I particularly want to thank the California Department of Public Health and the U.S. Surgeon General's office for the enormous amount of time and commitment that they've put into making today possible. So thank you, everyone. And you may wonder what that chart is over there to the right. I want to introduce you to our collaborators from Lizard Brain, Lauren Green and Rachel Thompson. Lauren's there. Who will help facilitate our conversation today. They'll be creating a record of what you are sharing, which will also help us towards the end of the day in guiding our next steps. So thank you for joining us today, Lizard Brain. I looked at the registration last night, and you come from, I think it's more than 23 states across the country with all different kinds of experience and context. We have people from Mississippi, North Carolina, New York, Alaska, et cetera. I won't name all 23. But just to say we have diversity in the room. We have people from tribal lands, from our biggest cities, and from rural areas. From the federal, state, and local agencies and government. From private sector and nonprofit sector. You are doctors, pharmacists, frontline healthcare workers, tribal leaders, probation officers, researchers, sheriffs, and activists. And we welcome you all. And I want you to take a moment and look around the room and find some people that you have not met with before. But we've actually masterminded this a little bit. The number on your name tag put you at a table. And that table is supposed to have people from different sectors. So if you didn't sit at the table with your number, you might mess up our ability to mix you up. And we know you want to meet with your friends and colleagues that you know, and you will have plenty of time for that. But actually what we want is for you to spend this morning with your table. You'll be doing some tabletop exercises where it's really important that we have different sectors. So if you're not at your table, when we have a break, you can walk to the table you're supposed to be at. So one of the things that we realize is that the people in this room, you're all caregivers. And that's something you have in common. And you may not think of yourself as a caregiver. Maybe you care for children, maybe you care for patients, but you're all here today because you care about the results of this opioid epidemic on family members, on friends, on patients, and on your community. And we know it has devastated all of those different units of our country. We're going to ask you today to draw on what you have in common. And we're also asking you to push the boundaries, to think a little differently, to be open to new ideas, to share what may be personal if you think it will benefit someone else who could also take that learning that you've experienced. So please take every opportunity to connect with people while you're here. And as I said, we designed the meeting so it's very interactive and so you can ask questions. We're going to stick to our time because we've built opportunities for you to discuss and ask questions. And one of the things that we also want to make sure is that each of our speakers is going to be talking about equity. This is an issue that we're asking you to put in your frame. Who's been left out of our interventions? Who's been left out of our funding, our media, our language, the way that we talk about opioids, the history in this country of opioids? And just a little context, the mortality rate amongst African Americans rose by 25% in 2016-2017 due to opioids, 25%, compared to an 11% increase in opioid deaths among white populations. And yet, white populations are almost 35 times more likely to be offered buprenorphine than Black Americans. And people who have been involved in our criminal justice system, people who are Native American, people who are non-English speaking, are also particularly vulnerable. So when we're spending the day, let's make sure that in looking at our work and looking at the future, we're looking at the equity impacts. So Matthew mentioned, if you haven't yet, please download the app. The URL and QR code are in your print program at your table. And he also mentioned that we will have a book signing at lunchtime. Ingeveld Olsen and Josh Sharfstein are here. They're two of our speakers. And USA Today actually features their book in talking about the opioid epidemic, so you can get it hot off the press. Next, I'd like to invite Dr. Karen Smith, who's the director of the California Department of Public Health, to join me. Dr. Smith is a physician specializing in infectious disease and public health, and she previously served as the public health officer and deputy director of Napa County Health and Human Services Agency here in California. She served as clinical faculty on the Santa Clara Valley Medical Center Division of Infectious Disease and in the California Department of Health in the Tuberculosis Control Branch. She's had several positions at Stanford University School of Medicine, and I value Karen as a friend and a colleague, and PHI has had a long partnership with the Department of Public Health, and we're grateful for her joining us here today.
I just wanted to say how exciting it is to see this come together and to bring people from so many different states. There's a lot going on in California around the opioid epidemic. While some of our numbers don't look as frightening as some areas of the country, we have over 2,000 opioid deaths a year. That's a lot of people dying. We have tremendous inequities in who's affected by the opioid epidemic. What we're doing in California and what we've been doing since 2014 is essentially using a collective impact approach to addressing this epidemic from every possible sector. And we are, beginning in 2014, my predecessor, Ron Chapman, as the state public health officer, convened a group of 9 state agency and departments to talk about the opioid epidemic from across the administration to say, what can we as an administration do? That continued to function, aligning our efforts. Everybody stays in their own lane. It's government, after all. We wouldn't want to waver. But everybody continues to do what they do, but they do it in alignment with a set of shared goals. And I think everybody now is probably pretty familiar with the power of a collective impact. In 2016, we expanded the group to include our other key partners, including the California Healthcare Foundation, which has been a real leader in California, but also the Department of Justice, the U.S. Department of Justice has provided support as well, or participation at any rate. The DEA was actually the first group to want to join because they recognized that their approach wasn't all there was to fighting the opioid epidemic, and they wanted to know what they could do in other areas. Our efforts are essentially, right now, at this point, we have 25 different state agencies and over 40 partners working in 5 task forces on everything from neonatal abstinence syndrome to MAT to community interventions. And we are organized around basically 4 areas: preventing opioid use, misuse and overdose, and death. And that is all of our upstream work, a lot of which is going on in communities. You're going to hear a lot about the over 40 of California's 58 counties are involved in some form of either a regional or a county level opioid coalition. And they're doing amazing work. Every time I talk to somebody, I hear something new and different. Each community is different, and each community needs to own this issue and help us adapt to them. We also, so there's preventing, managing people who have chronic pain, doing it safely, trying to prevent new starts, and where you do have people who are on opioids, how to manage them, get them down to levels that are not life-threatening if they're absolutely necessary, and increasing access to alternative care. And then there is the whole issue of treating people with substance use disorder, and this is a big push. As is always the case with anything that has to do with healthcare, it's also the most expensive push. But we've been very lucky in California with substantial increases in funding, both from the state, but most importantly from the federal government. Our Department of Healthcare Services is doing tremendous work expanding the access to medically assisted therapy across the state of California. But as is, California's Department of Corrections, unfortunately, has a population higher than many states. And over 80% of those inmates in those prisons have some form of substance use disorder, and the majority of them use opioids. And many of them were actually addicted upon entry. And the issue of getting those folks on MAT has been like beating your head against a wall until recently when they have adopted a plan. It's not for, the folks wanted to do it, it was really where are the resources. Well, the last budget has included significant resources to be able to build out MAT for every single person who needs it in our prison system. And they've already begun working on those incredibly important intersections when people get out in that community. And once again, community is at the forefront of that. And then finally, stopping overdoses and deaths, especially deaths. So huge efforts in expanding naloxone, making sure that, as the Surgeon General says, and by the way, I do carry it, thank you very much, that everyone should have naloxone, and certainly everyone should have access to naloxone and understand its importance. And so we have there's way too much going on to talk about, but we still learn every time we come to a gathering. You'll find there are a lot of folks here from the state of California who are really interested in learning, and many people from our local jurisdictions who you will also hear from today. So thank you for coming. For those of you who came from the East Coast, I hope you enjoy the lovely weather and lack of humidity, because I do.
Our next speaker, Phillip Talbert, is the first assistant U.S. attorney for the United States Attorney's Office, the Eastern District of California. As first assistant, Phil assists the U.S. Attorney, including their work in investigating and prosecuting opioid diversion, trafficking, dark web sales, and issues related to the importation of synthetic opioids, including fentanyl. And for those of us from San Francisco Bay Area, just the other day it talked about how that is increasing significantly, and I'm sure Phil can attest to that, in the Bay Area, which I know it has been devastating the East Coast for a long time. Phil has been Assistant U.S. Attorney in this district for 17 years, first serving in the Narcotics and Violent Crime Unit in Sacramento, where he prosecuted drug trafficking cases, and then serving as the Chief of Appeals and Training, where he supervised the office's appellate practice and trained incoming Criminal Division Assistant U.S. Attorneys. Please join me in welcoming Phil Talbert.
Thank you, Mary. And good morning and welcome to sunny Sacramento. Again, my name is Phil Talbert. I'm the First Assistant United States Attorney for the Eastern District of California, which is headquartered here in Sacramento. First, let me begin by thanking all of you for coming to this important conference. With opioid abuse reaching crisis proportions in this country over the last few years, it's more important than ever that public health professionals and law enforcement officials share information and ideas so that together we can address the related problems of abuse and addiction on the one hand and illegal drug diversion and drug trafficking on the other. Let me draw a sketch of the problem from my office's vantage point as the office that prosecutes violations of federal criminal law in the half of California that includes the Sierras and the Central Valley, from the border with Oregon down to the north edge of Los Angeles County. First, we're seeing tens of thousands of counterfeit pharmaceutical pills, largely hydrocodone and oxycodone tablets, fake, being sold inside of our district and traveling through our district via I-5, Highway 99, and I-80 out to other parts of the country. Some of these pills are being made right here in our district by drug traffickers using small pill presses. These pills are made with the same color and markings as the legitimate prescription painkillers that they mimic, but the active ingredients are instead small amounts of heroin or fentanyl. Other counterfeit pills we're seeing are made outside of the United States and smuggled into the country, mainly across the southern border with Mexico. These pills also are made to look like legitimately manufactured prescription medications, but they also contain heroin, fentanyl, and other drugs. Not surprisingly, the drug traffickers who make all of these pills aren't trained in dosing, and the machinery they use is not exacting like that used by legal pill manufacturers. That means that anyone who takes one of these counterfeit pills is literally taking their life in their own hands. In fact, here in Sacramento County, we had a rash of counterfeit pill overdoses in 2016 that led to the deaths of 15 people. They thought they were taking diverted hydrocodone, when in fact they were taking pills made with fentanyl. We've brought a number of recent cases against defendants who've made and sold tens of thousands of counterfeit pills and others who have shipped them from here to other parts of the country. In addition to seeing counterfeit pills, we're also seeing large amounts of fentanyl trafficked in or transported across our district. Fentanyl is being trafficked in multi-pound amounts in our district, just like methamphetamine, cocaine, and heroin, often by the same polydrug organizations that traffic in those drugs. And since a small amount of fentanyl goes a long way, a pound of fentanyl purchased from a trafficker for thousands of dollars can be turned into a huge amount of pills that can be sold for millions of dollars. We've brought a number of cases against traffickers who have transported or sold pounds of fentanyl. Sometimes the fentanyl is used to lace another drug, or sometimes it is simply used to replace one. For example, we currently are prosecuting a case in Fresno in which 4 people overdosed, 2 of them died, after snorting what they thought was cocaine, but was in fact fentanyl. We're also seeing over the past several years a new avenue through which people are buying and selling counterfeit pills and fentanyl, as well as other drugs, the dark web. Through one of the marketplaces on the dark web, buyers and sellers of contraband can engage in transactions while remaining mostly anonymous, using pseudonyms and digital currency. Today, with the click of a mouse and a cyber wallet of Bitcoin, a teenager in Sacramento can purchase opioids on the dark web anonymously, and the pills will be delivered to her door the next day. There's no need to borrow the family car. There's no need for a stash of cash. The teenager can do this from her own bedroom, just like ordering a book from Amazon. My office has prosecuted a number of sellers on the dark web, and in the summer of 2017, we took down the largest dark web marketplace for contraband in history, Alphabay, which was run by a Canadian citizen from his home in Thailand using a server in Lithuania that he accessed through computer networks in many other countries. Finally, we also investigate evidence that medical professionals and pharmaceutical companies are diverting legitimate pharmaceuticals outside the usual course of professional practice or are failing to maintain safeguards the law requires. For example, we charged a doctor for a pattern of prescribing Xanax, hydrocodone, and other opioids outside the course of professional practice and not for a professional purpose. We charged a pharmacist for filling fraudulent prescriptions for oxycodone and hydrocodone and distributing the drugs through co-conspirators. And we charged a nurse with obtaining tens of thousands of prescription opioids and offering them for sale on the dark web. Additionally, our civil attorneys have investigated and obtained multi-million-dollar settlements from pharmaceutical distributors who failed to maintain required records concerning sales of opioids or who failed to implement adequate controls to thwart diversion of opioids into illegitimate markets. Combating the opioid crisis is one of the top priorities of the U.S. Department of Justice and the U.S. Attorney's Office here in Sacramento. In 2017, the Attorney General directed every district to appoint an opioid coordinator and to have that person create a district-specific plan. We've done that, and in our district, our coordinator follows the cases and trends in our district and makes frequent presentations to various local and statewide groups. Our goal with these is to build relationships with people working on the issue and let them know what we're seeing from our perspective. Last year, our opioid coordinator helped us host an opioid awareness summit attended by 400 mostly medical professionals. The day of presentations discussed our office's take on the epidemic, funding priorities for new grants issued by the state of California, and perspectives from pain management specialists, doctors, and people running public health clinics. Additionally, in recent years, the Department of Justice has increased funding for new prosecutors in the U.S. attorney community, including for opioid prosecutions. In addition, we were one of 10 districts nationwide who obtained a new prosecutor to prioritize fentanyl prosecutions. Despite receiving those additional resources, though, we cannot address the problem alone. While my office's primary statutory mission is to enforce federal criminal law, our country's opioid crisis is not going to be solved solely through disrupting the supply chain and prosecuting suppliers. We can't prosecute our way out of this. Only by treating addiction, educating the public, and ultimately reducing demand can we as a society ever hope to end this epidemic. That's why it's so important for those like me who work on the supply side of the problem to coordinate with those who work on the demand side. Combating this crisis really requires a team effort. For example, when those in the medical community see a strange overdose or a new trend, alerting us can be incredibly helpful because we in the law enforcement community may not recognize something new or a change in behavior until months and months later. Let me take this opportunity to introduce from my office Sean Vassar, who's with me here at the front. He's our community outreach coordinator. Thanks, Sean. If ever you need to contact our office or you want any information, obviously you can contact me as the first assistant, but you can also reach out to Sean if you can't reach me. Again, thank you for joining us here today. I hope this summit is valuable to you in what you do, and I hope it helps build relationships that will lead to partnerships in battling the opioid crisis that we all face. Thank you.